we invite you, Dr. MINU, to give your talk on heart-stopping moments during IOL implantation.
Before heart stops, hair will rise. So first is hair rising, then heart stopping. Okay. So can we have the slides down, please? Thank you, Dr. Sudeep and Dr. Suvira, for this opportunity. We'll go on to no financial interest at all in any of these lenses or whatever is being shown. So this is my trainee doing. You can see a posterior capsule rupture here, and an IOL vitrectomy is done. Cortex is nicely aspirated, and whenever you want to place a lens into the sulcus, what happens? It goes into the bag. And if you want to place it into the bag, it goes into the sulcus. So it goes in. I told her, stop, it is going, you take your skin, hold it, hold the forceps and hold. She suddenly started shaking and then asking for some other instrument. Again, visco, and suddenly gone, dim. That's it. So don't panic. But it's very easy to say don't panic, but then if you don't find the right instrument, use some instrument and hold on to the IOL before it drops. Okay. Okay, this is my case. IOL is going to go in, and everything is done fine. I am not bluffing, everything is run fine. No PC, nothing, no problem. Just aspirating the visco behind the lens. So just after that, when I look at the PC, 2 lines. So I thought I'll just leave. I'll zoom up and see. Okay, zoomed up. What did I do? Nothing. Just place the lens and washed behind. But now, when I pull the iris and see, it is not a PC rent. It is just 2 cortical fibers which are sticking to it. So sometimes very easy to get fooled by this, and sometimes if it is so also, don't pull and manipulate the IOL too much. It will stay there if there's a tear after placing the lens, and if it is not too large involving the area of the haptic. So this is another patient referred to us, and very funnily, the haptic is lying in the AC. IOL is inside. And IOL is in the bag and is very well centered. And haptic alone is floating and sitting on the cornea and causing corneal decomposition. So here, what should I do? I don't have to touch the IOL at all. IOL is very plastered inside, the optic is plastered inside the bag and well centered and all those. I don't know how it is so, but then still it is plastered. And the haptic is just retrieved off from the area of contact and then removed off. So these kind of bizarre things can also happen. People will leave one haptic free inside and send it to us, take it away, and all those, and patient will say, I cannot see now, after you have taken that something out, I cannot see. So that also is a problem, you know. So tell them that your lens is in bits and pieces, and so I am not responsible. So this one is my own one. See, look at the haptic. See, I cannot pause this here. That is the problem here. But the way the lens went inside, and this again, look at this one here, the haptic. The haptic should not be facing towards your right. It should be facing towards your left only. See here also, see, look at this. The injector part is overriding the optic, the tip of the plunger. That is what happens when this is what happens when that happens. When the tip is not bent and it becomes straight after multiple uses, it overrides over the IOL, and there is a tight junction, and you use more pressure, and it flies in like a missile, and it went inside, nothing happened. I thought it was all okay, and then okay, we'll aspirate everything and pull and see, push, nothing is there, so I'm happy. And but just see my arrogance, keeping on going there, keeping on aspirating there. What is there to aspirate so much there? Nothing is there, but still going on to that corner and keeping on aspirating. But then we realized that there was a little bit of vitreous there, and now if you see peripherally, there is a tear because of this missile going and hitting on the equator of the bag. The PC has torn there, and I pulled vitreous also there, aspirating it. So finally I do a little bit of vitrectomy. Haptic is well oriented away from the rent, and so you don't have to do anything on this, just leave it after doing a little bit of vitrectomy. Okay, another case. IOL is going in, not willing to come out. Haptic is not coming out. Trying to push, haptic is still stuck somewhere. And now I get to retract, but then IOL decides to go in. I come out. And so one haptic is not in, the other haptic is there. So it happens with all these butterfly cartridges, where one of the tip of the haptics do not go in the right place, and it gets caught between the. So I pull it out, keep it in the anterior chamber, put sodium hyaluronate into the bag, and then place another IOL into the bag after this. So I have always 2 IOLs of the same power of all cases, and then 3-piece IOLs of all powers. And this Apasami long straight Vanna scissors works for me for all cases. No financial interest in this, but without enlarging the 2.8 incision, I can cut any lens with this. Very sturdy instrument. But then if you have noticed, I hold the lens from the left hand on the optics so that it doesn't tilt. And after one half is taken out, see, the point is that if you place the IOL in, then you don't have a scare of touching the PC with the tip of your scissors. And also we should be careful not to cut on the rhexis margin or the iris margin. So once you go halfway through, you don't have to go full length. You can rotate it, bring it back, and then cut the uncut area close to you. You don't have to go very far. So here again, this is a femto case. So rhexis is fine. I'm just showing you. Just keep looking at the rhexis here. The capsule is intact, and the IOL goes in again. I'm a big shooter. Again, this shoots, and then it goes in, but it goes into the bag. And after that, in this case, what happens is the capsule, anterior capsule margin tears. See, look at the anterior capsule here. So I can preferably shoot on the posterior capsule, on the anterior capsule, anything I can do in the anterior chamber. Just to show you that in femtos, there may be weak areas which may open up on pressure. It would not have happened if it was a regular manual rhexis. So this is again a single piece hydrophilic IOL, and here this is a little higher power IOL, close to 2830. So these kind of lenses are bulkier, and once they go inside, see, these some of these cartridges are not well made, you know, the tip of the cartridges, and injection was going on well, and suddenly you feel a giveaway like this. This is when the injector tip bursts open, splits open, and the tip is inside, and this is open here. See, the plunger has come out of this one, but the my haptic has been caught between the plunger tip and the cartridge. So here what we can do is to keep steady there and then split open the uncut area. Partially it is already split, so join that split to the tip of the curtain. Make sure you don't cut on the haptic. If you cut on the haptic and damage it, you'll have to explant the whole lens. But if you do not, then we can gradually open this cartridge up and then release your haptic and see whether it is damaged. If it's damaged or cut, or if it is too bad. If it is just a cut, that's okay. But if there is loss of material, then please always explant and place another lens. So this is a regular capsular rhexis. I'm just showing that the capsular rhexis is complete, and then phaco finished. So nothing big about phaco. So this single piece Technis lens goes into the bag. Remember, when you do not inflate the chamber or the bag very well, sometimes even very fine soft looking lenses can rupture your posterior capsule. So injected a little bit more into the bag, and the bag was not fully opened, and see, was fully opened with visco, and see the line here. So I don't still believe that there is anything there, is just a line. So I aspirate whatever little cortex is still left there, but then I realize that it is a full tear which is extending from one limbus to the other, and it's inferior also. So in such cases, I do not want to leave this single piece lens in the capsular bag, and I again go back, put in sodium hyaluronate, and in all these cases I do put in cohesive viscoelastic, no HPMC, no dispersive. Dispersive is very difficult to take out, but dispersive, if you feel that you want to plug the piece end area, you can put dispersive there, viscoat I mean, no financial interest in that. Then after that, in the anterior chamber, I would use only sodium hyaluronate, which will completely come out and will be fully taken out. So I could have left it there, but the haptic, see, it is into the area of that large rent there, and it is inferior. So this will definitely decenter and should not be left into the capsular bag, and that is dialed out into the anterior chamber. In the same way you saw the previous case happening, I place a 3-piece IOL into the sulcus when the IOL is still there and over the rhexis margin, and then cut this lens and explant. So this is the 3-piece lens getting loaded. The Technis also, it needs a slightly larger incision, no struggle of wound assisted and all those stuff. Increase it to 2.8 or 3 or 3.2 if you want, and place it under the IOL. This is going under the IOL on top of the rhexis margin. So have a clear view of the rhexis margin. If it is constricting, use dilating drops intracameral, or dilate it with hooks and have visualization of the rhexis margin, and then only place the IOL in the sulcus. Once that is in, this IOL can be cut and taken out again. You want to see the cutting again? No, you have already seen the cutting. I'll just forward, because I can't forward it here because there is some problem in the alignment here. So the IOL is aligned in such a way that you can hold from the side port the margin of the lens. That is very important, so that it doesn't tilt. use this, cut across. If you partially cut also, you can rotate it and then take, there are different ways of cutting. You can cut a pie out, you can cut it into 3, you can partially cut and pull out. See, I don't want to strain the incision. Partially cutting and straining the incision and pulling out and all doesn't make sense. You make it into full, this is 6 millimeters, so you need more than 3 millimeters to take it out cleanly. Don't strain your incision. Make it at least 3 millimeters and take it out cleanly so that it closes well and it doesn't damage the edges and cause astigmatism. So my next talk for 3 minutes is wound burn. So nowadays it's not that very common that you get wound burns because we're higher end machines and a lot of modifications have happened in the but many times when you have hard cataracts, this is 3 minutes, 2 minutes, fine. So once you finish, happily you're doing, and then you see this. Many times you don't realize because of the color of your sleeve and all this. So basically, what is the problem? There are 3-4 problems. One is the size of your incision and the size of your sleeve. Machine company fellow people, they always have a tendency to tell you that this will go in through 1.8, sir. This is between 2.2 and 2.3 and also. See, whenever they say that it is slightly more than something, have it slightly more than what they say. Because they will always want to say the smaller size and say that it goes through the smaller size. So if you want to, if you have to squeeze your tip inside, then it means that it is tight for you. Make it slightly larger, so that the fluid flow happens nicely through the sleeve on the incision. That is where it burns. And then the incision part, if you see this incision, it has to be adequately, see 2.8 is also fine. Sometimes the keratomes are not good enough. Some keratome, they say it is 2.2, but when you put in a new sleeve also, it will be tight. So try to find out what your keratome is and then stick on to your keratome and know your keratome. I always have one company's keratome. I just need to extend 0.1. Then only the 2.2 goes in very well. And here again, the next problem which happens is we look at the tip and forget to look at the incision. It's not possible to look at both during with the microscope, you know. And so we will be pushing towards the side, we'll be pushing towards up, tilting more. Tilting more means the upper part of the sleeve will hit against the incision and no fluid flow. And the heat gets transmitted directly. 2 other situations. One is the tip getting blocked with viscoat. See, put a lot of viscoat, you're happy, cornea will be, endothelium will be saved. And viscoat doesn't get aspirated that very easily into the this one. So viscoat goes inside and it plugs. And then when you go in with phaco, no aspiration happens momentarily and no irrigation happens. And phaco power is on and you directly transmit the heat. Second thing is you have the tip or the tubing blocked with a nucleus piece, and you don't realize it and you continue to do phaco, and then also you transmit it. Once you have this, and if it doesn't close by your hydration, please suture. 100% suture. A horizontal suture will be good to close it, close the lips together, and if it is good enough, fine. So one bite along the floor, come up on the roof, and then take another bite on the roof and come down in the incision and tie it in, and still make sure it doesn't leak on the table. You dry it and see. Spontaneously it should not leak, and also while pressing on the other side it should not leak. Press on the limbus and see. And the last one is making multiple radial sutures. One suture, it may be very small incision. 1, 2 or even 3 may be required to completely close it. So make sure that you completely close it, and sometimes it induces a lot of astigmatism. Can't help it if it burns so badly. So try to keep looking at your incision also whether some color change happens, and make sure that you don't press on your one. See, multiple sutures I am making, then it closes. So 1 of time we'll stop. Thank you very much.
Thank you so much.